over your shoulder.
Yeah, I know you're looking at Mike.
And you want to go?
Oh, you're asking him, are we ready? Are we ready?
Great experience for graduate school.
Are we ready, you guys?
I'm ready. Rock
to
and
go.
roll.
All right, it is 5:33, 5:32, depending on what clock you look at. Let's call to order the Central Hope Board of Managers meeting. It's Wednesday, November 15th. And welcome, everyone. We have one person signed up for citizen communication, Zach Webb.
And he has been given a copy of the process of guidelines.
Okay, sounds great. Mr. Webb?
Sure. Is this a good place to sit?
Yep. Make yourself at home.
Hello, everybody. I was at your strategic planning committee meeting yesterday and heard a great presentation on the what's happening so far with your public education initiative. And I just wanted to give a few comments back about that. It seems that with the initiative that targeting your patient population of low income and uninsured residents of Travis County, as well as advertising the services that you provide to that patient population, seems to be an afterthought in the campaign, that instead you're focusing on homeowners and brand recognition, which has its own advantages, but I feel it kind of falls outside of what Central Health is supposed to do. And when you look at the amount of resources you're devoting to this campaign, going from $11,000 in FY16, jumping for your marketing and public outreach, up to over $1 million the subsequent 2 years, seems like quite a jump to have the result, the most visible result, be these billboards that just say "Healthcare for All." I just want to throw out an estimate, a little back of the envelope thing I did. If you estimate that a patient encounter with a physician to be about $300, then I just wanted to point out that your budget for this campaign of over $1 million would have otherwise provided 3,600 patient encounters. So if you view the campaign in terms of that, I would like you also to analyze the efficacy of the campaign in terms of what the money could have been spent on. And that's all I have to say. Thank you.
Thank you.
Thank you. I want to skip around for 1 second and skip right down to the committee update item. Sherry, looking at you. So item 7, receive and discuss reports from the following board committee: strategic planning committee. I was not here last night, but I got a report.
Right.
And so I think maybe what you discussed might address what Mr. Webb just raised, and I wonder.
And I think it would be good perhaps to have Ted and Lisa at the table. Potentially, I don't know, but potentially, related specifically to this item. So we had a wonderful presentation last night from Ted and other staff, and three individuals from Sherry Matthews came. And first of all, I think that there's been some misunderstanding about our budgetary numbers. Lisa, is that something you could address?
Yes, I believe the budget for the project was $500,000.
Right.
It did cover, we budgeted $500,000 last year, but we only budgeted $250,000 this year because we did not spend it all.
Correct.
It kind of carried over through the fiscal year.
Correct.
The entire project, even though we were well under budget last year.
Yes, we were.
And then just half of that was budgeted this year.
Correct. So
The project should be not, it was $500,000.
Right. And so just wanted, and within that project, and Ted, you can address this, I know, is some money even within that project for ACA enrollment. Is that correct?
Yeah. So
Okay.
some of the paid social media is
Yes.
specifically about enrollment in the ACA.
Okay. So I just wanted to make sure that we had the correct numbers. I think that's important. And also, I don't know if the reference to the spending in prior years was correct, and that might be something, Lisa, that you could.
Look into that.
Yes.
It was definitely not.
It's not. So I would just ask if you all could look into that and provide the correct numbers. That would be helpful, I think, for everybody.
Absolutely.
And then, thank you. And beyond that, we had a very robust presentation talking specifically, I think, about how you reach different people in different ways. And they did a lot of research, as you know. They interviewed many of us in this room and spent a lot of time with us. They did focus groups of a variety of people, including our clients. One of them even went to Southeast Health and Wellness and interviewed people there too, did more research, came back, did more focus groups. Am I correct, Ted?
Correct.
So a lot of research, and a lot of research also into how you reach different people that we're trying to reach. And for instance, they were saying that for reaching our clients, and this is something that Cynthia had spoken about in previous meetings, that for reaching our clients, social media and Facebook is a very good way to reach our clients, and radio is a very good way to reach our clients.
And transit advertising.
And transit advertising, and I'm really pleased that Sherry Matthews was able to leverage for us with no cost because of some programs that Capital Metro has that they work with them on, the advertising on the buses, which is really key for our clients. I also know that we've had some multiplier effect already, I think, Ted, with an interview that you had, is that correct?
Correct. So part of the added value that the Sherry Matthews team negotiated was with iHeartRadio. And so Michelle Tiarina, our community outreach director, and myself did an interview today, and that interview is going to run on, I think it's 5 different radio stations over the next 2 weeks. It's public service announcement. We talked specifically about ACA enrollment
Right.
and the services that Central Health provides and how we do that.
So there's a lot that's being done with specific research on how to reach the clients. And then there's other aspects of it that are to reach people who may not be our clients, but certainly are taxpayers. And we have an obligation, as we all know, and are all very serious about, to be transparent and to let people know what we're doing, who we are, how their money's being spent. But also to keep in mind that some of those people may not qualify, but may know people who do. And in fact, I don't qualify, but I know people who do. Yes, most of us do. Most of us may not realize that we have friends and neighbors, right? Particularly with the fluidity in today's economy, right? And so many people doing contract work and things like that. So excellent presentation. Also, we were able to see some of the spots in Spanish and English, and I think the radio too, didn't we listen to that in Spanish and English? So that's a summary of part of the meeting that we had last night. Another portion of the meeting before that was a wonderful presentation from our staff. One was from the effort that we head up regionally with DISRIP on the Region 7, on data and robust data that they collect every 5 years. Of course, that's from the whole region. Another was from our staff from JP, who is just doing excellent work, and really it's a lot of work what he and other staff are doing to update work that was done about 2.5 years ago and add more to it with demographics in Travis County and GIS mapping and services, and even looking at subsidized housing. He was able to give us kind of the high view. There's still, as I say, slicing and dicing the data. But at our meeting that we're having November 30th, which is being held down at the county, he will have a report. And then Mike, not this Mike, the other Mike, gave us an excellent update too on some of the continuous improvements that are being made to our website, and some things that he's looking at, and Mike Giesland is looking at as far as providing a dashboard and a one-stop shop for data that will be helpful, not just to us, but to our staff and, of course, to the public, to have that one-stop shop, and with using Tableau and data visualization. And we also talked about some board training, an opportunity that we're having in small groups to be able to do on social media. I think, did I miss anything?
I just wanted to add one thing. What I was pleased to hear, and that hadn't really read, is that the consultant, Sherry Matthews, in your office will be able to give us some outcome data, which will show
Absolutely.
like how many hits we
Yes.
had based on whatever ad or if it was a radio spot or whatever, however they're going to gather that information.
And
Let us know, but especially with respect, to me, what's urgent right now is ACA, education and enrollment.
right.
Because that ends December 15th.
exactly.
So the more targeted, at least, I guess Michelle's group and y'all for getting those messages out ASAP. The public needs to understand, for those of us that need to enroll in ACA, December 15th is the cutoff deadline.
I-
So that's real important.
I appreciate that, Cynthia. It is crucial. And I will say that there
And-
are, sure.
And that this could be the beginning of a progressive public education campaign. So there may be other issues that we need to hit on right now. They're pushing out Central Health, but what we offer, how
Right.
to enroll, blah, 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 those kinds of things, who qualifies, anything that we can do to educate the public as to what we do, especially those people that don't have insurance and don't have access to services that we offer, that's a good thing.
I agree, and you brought up an important point, which is there's so many people who don't even know that Central Health exists, or if they hear the name, they think that we're some kind of, I don't know, insurance some sort of corporation, or, we're making widgets. They don't know what we do. So very important, as well as emphasizing, and that's why I'm glad we had extra effort within this effort, even on the ACA. And on the outcomes, we're going to be looking beyond the traditional outcome measures, also to what I call the multiplier effect, to see if there are additional benefits that we're getting from this, such as additional free media placement and things like that, because that's important if we can leverage that into,
We've negotiated for that, so we will be getting added value, so
Right.
extra, the spots will run more than we're paying for them as part of the
Wonderful.
package.
wonderful. I think that's it for the time being.
Good. Well, I hated to miss yesterday. I got stuck at work, but I really,
happens.
I love the campaign. I love the message around healthcare for all. This point that has been far too long the case, where we have a bifurcated healthcare system where low-income people have one healthcare system and people who have access to coverage have a better system. I think the message is right on point, that we provide healthcare for, our focus is the low-income people, but our system is the same system that everyone uses. I love it. I
That's right.
thought it was right on point messaging-wise.
I would also comment, thank you so much. And really, as we are inclusive to everyone in the community, and that message, which is a universal message that is used worldwide. And
Right.
I commend you on your hard work, and thank you. And it's great what we're doing and bringing awareness to the work that we do in Central Health.
Thank you.
Thank you.
Thank you for the update.
You are welcome.
Okay, so I'm going to take things out of order. We have some guests, and to respect their time, or some staff who've stayed over to respect their time. I'm going to go to guests first, though, sorry. We're going to start with item 4, receive and discuss a fourth quarter update on community care operations for fiscal year 2017. And I think Jason and Carolyn, are you two going to present to us? And then Megan.
Item 4 or item C4?
Oh, let me, real quick, sorry.
Do the
Yeah, let me
consent.
do the consent agenda while you guys pull up your slide deck, which you already have that.
You need a motion?
Well, let me read the item real quick. So let's real quick do the consent agenda. Item C1, approve minutes for the following meetings of the Central Health Board of Managers, October 25th, 2017. C2, receive the October 2017 investment report and ratify Central Health investments for October 2017. C3, receive the Central Health investment report for the fourth quarter ending September 30th, 2017. And C4, approve the fiscal year 2018 broker-dealer applicants for conducting investment business with Travis County Healthcare District as recommended by the Travis County Cash Investment Management Department. Do I have a motion to approve the consent agenda?
So moved.
Second.
Second, all in favor?
Aye.
Any opposed? Any abstentions? All right, thank you. Now we'll go back to item 4, receive and discuss fourth quarter update on community care operations for fiscal year 2017.
Great, thank you. And thanks for the opportunity to the Board of Managers for allowing us from Community Care Health Centers to go ahead and update you on the end of our fiscal year and the results that we were able to obtain through your support through Community Care Collaborative, and also as a federally qualified health center operating in conjunction with Travis County Healthcare District. So at this point in time, I'm going to turn it over to Carolyn to go ahead and walk us through, and then I'll speak a little bit towards the end as well. So thanks again for the opportunity this evening, everyone.
Good evening. We're happy to have good news to report to you. I'm not going to read every single item on every slide, but I will say that our encounters are better than they've ever been. We provided care to a record number of patients. So our year-to-date encounters were 16,484, or 5% greater than the previous year. So the previous year is the far left, the right is the current year, and you can see it's higher. The budget is in the middle. And we have a nice trend line over the last 5 years. We, of course, have more years than that, but 5 seemed like a good snapshot. Over the last 5 years, we have a 27% increase in encounters, so we're pretty proud of that. In addition to these are our traditional encounters. We also, as part of the value-based care initiative, we provided for MAP patients an additional 59,000 nurse and medical assistant visits, 7,200 pharmacy visits, and 3,700 nutrition visits. So what did that do for us for the year? So it turned out positive for us. Those number of encounters compared to budget, we managed to keep our expenses lower than our revenue, so that we had a favorable outcome for the year of $2.6 million. But the big thing for us was that it kept our cost per encounter below our budgeted amount and below the prior year. So for us, that's huge and a first for us to be able to do that. And so now I'm going to turn this part over to Jason.
So I think, thank you, Carolyn. So this slide that you're looking at is about our provider vacancy. So of course, our ability to provide services across the 20 community health centers that we operate is dependent on the staff and our ability to retain and recruit high caliber staff. And this last year, we've been able to make significant improvements in terms of our recruitment efforts, and they continue across the country right now. Recruitment for primary care physicians and advanced practice providers like physician assistants and nurse practitioners has never been greater. We have a couple of really important assets. One is that we're in Austin, which is a favorable location for drawing folks into a very desirable location to live. Additional to that, we've been able to leverage our evolving relationship with Dell Medical School, and so we'd be able to actually hire several new providers in joint appointments, wherein they serve 80% of their time with us, 20% with Dell Med, and they're providing services to our patients. And so that attracts very high caliber folks as well. So what you're seeing here is a nice trend line from last October, and the blue is actually true vacancies. And then what you're seeing in the orange or the yellowish up there is signed offers. And so that's heading in the right direction. When we take a look at it, we only have 3 provider vacancies as of October 17th. You can see last December, January, we're at 14. You got 14 vacancies, and we expect our providers to provide between, if they're full-time, 40-hour per week provider, anywhere between 3,500 to 3,750, depending on the provider type in terms of annual encounters. That's a significant amount of service. So this is a very positive trend, and the work of our Chief Medical Officer, Dr. Shalsha, our Chief Human Resources Officer, Susan Willers, has been critically important, as well as our entire staff, in ensuring that we're bringing in good people to help provide services, picking up on earlier healthcare for all, right? for Central Health. We truly buy into that and really want to look at making sure that as we're providing the services, that regardless of how you're coming to us, you get the highest quality of care possible. And that starts with the providers that we're getting. Relative to our budget, as you very well know, one of the big components that's allowed for some of the expansion over the last 5 years is the Delivery System Reform Incentive Payment Program. And so we have benchmarks each year. So through the end of our fiscal year that ended at the end of September, we performed exceptionally well. We actually hit 99.7% of our targets relative to the clinical outcome measures. And these slides that are in your package, you can go through and you can see just how well we did relative to overall. One of the ones that I like to point out on this is dental expansion relative to pregnant women. If you look at the science and the evidence behind this, access to dental services improves the birth outcomes for patients and as well as for our mothers. When we take a look at that from a long-term perspective, and we hit that at 131%. So these these slides demonstrate the commitment of our staff and our partnership with our patients and with our community partners, including Central Health, to increase our capacity to serve in a very meaningful way that impacts health for our patients. Quality metrics, same as well. You can see across the board, the vast majority, except for one, the very top one, we hit all of our marks. We came close. Comprehensive diabetes, LDL, we're really talking about cholesterol control on that top line. We fell short of that, but we're actually moving towards and seeing some progress there as well. So each one of these, and the staggering one up there is really looking at our hepatitis C cure rate. Most of you guys know I'm fairly new to the Austin community as well as to Travis County and to community care. I can tell you there isn't a health center across the country that has hepatitis C cure rates with a patient population that would otherwise be seen as 53% uninsured. And so that is something we all should be proud of. We've worked very hard at that. I'm not taking any credit. I wasn't here to guide this. But I am now, and I'm very proud of the work that our staff have done with this. Those are meaningful changes within our patients' lives and the communities we serve. So as I mentioned, we hit 99.7% from a financial perspective. That helped bolster our revenues this year in a positive and meaningful way. So as we take a look moving forward, there's a summary slide I'll come to, but as we look into the current fiscal year, which started for us on October 1st, similar to Central Health, there are several challenges, and some of these challenges are very much external, and we wanted to take this opportunity to both advise the Board of Managers of what those challenges are looking like, that we're paying attention not only within community care, but here with Mike and Stephanie and others. We're engaging with congressional members. One of the biggest ones right now is that as of the end of September, for the first time since I've been involved in health centers, which is now 17 years, and for one of the first times in the 53-year history of community health centers, the federal government failed to reauthorize the program in terms of the funding. The program still exists, but 70% of our funding was placed at risk because Congress failed to act at the end of the year. We refer to that within the health center world as the health center funding cliff, and so you've got a cartoon up there, Wile E. Coyote. Unfortunately, he went off the cliff. Hasn't gone splat at the bottom yet, but it's getting close if Congress doesn't act. For us at Community Care and for Travis County Healthcare District, because we're joint applicants with the Federally Qualified Health Center program, it's $4.2 million in federal funds that will be lost for our program if Congress fails to act. So this is real. Our overall Federally Qualified Health Center grant is about 6% of our budget. And so unlike a lot of other health centers that have a higher percentage, we may be better positioned to absorb some of this, but this translates into services for our community. And so if we don't backfill, if this funding were to go away and we were unable to go ahead and backfill this, out of the 96,777 unique individuals we served last year, we would actually be unable to serve 4,000 of those individuals with the loss of funding. The good news is that it's passed the House. The bad news is it's stalled in the Senate. And so then more than likely it looks like the catch-all bill that Congress will pass at the end of December, where the debt ceiling is going to be addressed by Congress, is probably where it's going to land. It's going to have pretty much everything plus the kitchen sink in it. So we're staying tuned to that. You guys are fully apprised as it relates to district, but the other one that impacts us relative to, and you've heard in the media, CHIP, the Children's Health Insurance Program. We have about 2,500 of our patients are covered annually through the CHIP program. That translates into about $4 million for us in revenue. It essentially pays us at our Medicaid rate. As a community health center, we get an enhanced rate. Of that, of note, about half of that 2,500 are children. The other half are actually prenatal patients that are covered who would otherwise not be eligible for coverage at all. So these are mostly our women who lack documented status that are coming through the CHIP program for prenatal. Critically important program for the patients and communities we serve. So wanted to draw your attention in terms of the impact. We fully know that you guys are aware of the going-ons at the federal level, but wanted to draw your attention to the potential impact it has for us. And we're hopeful again that Congress will act before the end of the year. So the final slide that we have, I think, comes back to the encounter ones. It's a busy slide, but I think it tells a beautiful story. When you take a look at what are we about, so there's a lot of numbers in this report. It's a financial report to you as a board of managers, but this is about us interacting, engaging, and impacting individuals' lives, trying to effectuate change. You saw some of the quality outcomes. So when we take a look at this, this is something we're very proud of at Community Care. From 2012 to 2016, and in the fiscal year, we saw a dramatic increase in the number of patients served. We went from roughly 67,000 and a half patients in 2012 to almost 97,000 individuals. And you can see in the red bars on the slide up on the projection, being projected, you can see a dramatic increase in the encounters. And each one of those interactions has the potential then to add years to individuals' lives, and as importantly, the quality of their lives. And you can also see a trend rate relative to the overall revenues up at the top, which is listed in black, and then in the lighter blue is the expenses overall. So over the course of the 5 years, including our now fiscal year that just ended, so there's really 6 reporting periods up here, you can see that we've been able to manage the resources that you place in our charge very appropriately and trying to direct it to. Is there opportunity for improvement? Always. We will commit to you to make sure that we're doing that and trying to increase our capacity, not only to continue the services that we're providing, but to more comprehensively wrap our services to our patients in a manner that meets them where they are in a very meaningful way. So we're more than happy to answer any questions you may have at this time.
Cynthia.
I like the idea of you talking about the patients, but I'd like to know if you have any information that talks about the disaggregated patients, SFS, MAP.
Yes.
With insurance.
Yes, so our overall payer mix right now, so including in, when we say uninsured, we include MAP, so we can tease that out. But right now, our overall uninsured population for our patient population, including MAP, is about 53% of that almost 97,000 individuals, of which our MAP population is going to be about 22,000 out of the 54,000 individuals. We also have 27% of our patients are Medicaid beneficiaries, 6% are Medicare, and I'm rounding up a little bit. So, if you looked at the number, it would actually be 5.73 for Medicare for the last year. And that's something that's increased. When we look comparative to 2012, we were sitting below 4%. So we're serving more individuals who are either A, dual eligible, or B, truly aged through the program, the Medicare program. And then on the commercial insurance side, so private insurance, third party, it's 9%. And if you go back to 2012, we had almost no commercially insured patients. And so a significant transition from 2012 as a result of the Affordable Care Act and individuals gaining access to products through the health insurance exchange. So we're more than happy. We've got that broken up, and we can, at some point, we can go ahead and send through Mike, we can send a report that he can share with you that trends out the last 5 years as we've reported up to the federal government. It really dives deep into a lot of that information.
That's important to me, not only because I want to see how MAP has progressed or where we stabilized. I'd like to know where where our patient population is, at least for the last 5 years. And then with respect to ACA, I'm interested in the numbers with respect to ACA. If in fact we lose it, there's no more individual mandate, there's no more premiums. what can we do to create opportunities to our MAP patients, our sickest MAP patients, in order for them to gain access to services. So if we don't have that teased out, then I can't really, I really would like to see that.
Yeah, we can certainly get that for you, Cynthia. I think it's a great question and request. It's easy for us to get you that info. What I can tell you just off the top of my head is in 2012, our uninsured, which would have also included MAP, and this statistic was at 66%. Now it's down to 53 and change. So there has been a shift relative to overall uninsured within what we're seeing as folks have become additionally eligible. There's been an expansion at the state level as well as the Medicaid program and the CHIP program, which again, that has implications in terms of how it's shifted. So,
And we changed the eligibility standards in January of this year also. So, but I would like to see that, and
we'll tease that out. That part on the map, we don't actually show to the feds because they count MAP as being
Right.
uninsured.
Right,
So
that's right.
we'll tease that out as well.
but since we're concerned about our vulnerable population, that's what I'd like to know, because that's our target.
Absolutely.
And I have a question. What is improvement of PHQ-9 scores, all ages?
Sure.
What's
So
PHQ?
So it's a screening tool that we use to screen for depression.
Oh, okay.
And so really what you do is you look at that score, and it's a health questionnaire, that a patient health questionnaire 9, and it goes ahead and targets as a measure for depression. And then what we do is once you start treating depression, we look for a remission and a lowering of the score after 6 months. That's one of the standards that's out there in terms of looking at the tool. So, and with our patients, in terms of a lot of, as you know, social determinants of health and other factors are actually impacting how people feel. And so when you're asking someone without actually gaining more knowledge about the resources that are needed, someone who is struggling for housing or struggling to put food on their table or whatever is going to feel depressed. And so moving the margin on that PHQ-9 for our patient population can be quite challenging. And the fact that we're seeing that means that there's measurable differences going on within our population overall.
So as you work with IC, which is the old MHMR, the old ATCIC, and now it's IC,
Yes.
just because they're coming out with that new pill where you're going to be able to test the, I guess it's one of the pills that are going to come out that's going to be able to tell doctors whether or not the people are taking their meds that are suffering from depression, bipolar, schizophrenia, et cetera, et cetera. I was just wondering if that's going to be within our cohort of or whether or not there's a full discussion about that, because that sometimes can have the opposite effect.
So I don't know much about what
Yeah,
you're
that's a new
referencing.
thing coming.
We can find out.
Yeah.
It sounds interesting. So we'll talk with Dr. Schulchen and find out and our colleagues at IC to see that's got to be on their radar screen.
Okay.
We're the CEO and the CFO. It's, yeah.
So again, when we get those
One more?
information, this is it.
Okay.
So when we get these, I'd like to see the map.
Oh, sure. We can break out so you caught that, right, Carolyn? So when we take a look at the encounters, break out the map and the uninsured on that.
Encounters and as opposed to unique individuals as opposed to map.
You can do both, yeah.
Okay, thank you.
Yep, more than happy to.
Mark?
Congratulations on your increase in encounters and your increase in revenues and your decrease in vacancies. And I know that Dr. Coopwood is pleased about that, all that, but particular that last one. My question is, has there been a financial impact on the non-renewal of FQHC funding or CHIP so far?
No, oh, sorry.
There's still funding. In other words, you're still.
Correct. So CHIP is based on Texas and what Texas has in its coffers relative to it. So right now, it looks like Texas can fund the CHIP program through at least March of 2018. Other states, as of October 1st, they did not have funding. They had to deep into general fund revenue at the state level. For community health center funding, right now, there's monies available to Health and Human Services and the Health Resources of Services Administration through the middle of December. They'll start with the earlier grantees, so we expect notices to go out later this month. Our project period starts March 1st. So the earliest we would receive notice would be in January, and again, with the expectation that Congress is going to act before the end of the year, we think that notice won't come. But if you'd asked me a year ago, would we be in this position, I probably would have answered, I know I would have answered no. that there would have been a reauthorization of the funding. And
I hope that there are lots of people writing Congress about this. I mean, is this something that's getting what can we do, and those people who might be watching this broadcast write their Congress people? senators?
Absolutely. Reach out to your congressional member and let him or her know how important the program is to our community. We are actively engaged with our congressional members. Actually, we had the opportunity to host Congressman Flores at our Pflugerville site, and Mike was able to join me. He took the time and opportunity to spend almost 50 minutes with us, got a very good sense for what we're doing through Travis County Healthcare District, as well as understood the different model of care, which is an expanded care team, and indicated his support very clearly, and the vote in the House demonstrated that subsequent at the end of October. I think part of the issue is there's a lot of things going on in Congress right now, and so sometimes this one falls off the radar screen. So we're looking to engage with our senators in this discussion and to gain their support here in Texas relative to this very important issue. So any help you can provide in getting the word out, that would be greatly appreciated.
Thank you.
Yeah, thank you.
Ron?
Well, thank you. Appreciate it. I have two things. A, you were able to increase your employees by how many? What percentage did you?
In
Well, you're down right now to only 3 vacancies.
in terms of provider vacancies, correct,
Provider
yes.
vacancies. So and you mentioned clearly that now there's a joint employment with Dell Medical School, so about 80%. So my question is really, this is the value that the medical school brought to our community, even though indirectly it bring in really providers who can provide for our underserved. So it's just we don't really highlight it, and that's something that we should really mention it.
So unequivocally, that's the case. We've got 3 appointments, not counting Dr. Shalsha, because he's also spends 8 hours of his work week over at Del Med and allows us to integrate. We're working very well with them, and both the direct and indirect benefits from having a medical school and a new medical school are translating into impacting our ability to recruit physicians into the area.
High quality physicians.
Absolutely high quality, the highest quality actually. I think when we look at the docs that are coming our way as a result of this, we're gaining some highly skilled individuals because they're coming out of some of the state-of-the-art medical schools across the country, University of Wisconsin-Madison, George Washington, Duke, and so some really high caliber folks, yeah.
I'm glad that we have that opportunity indirectly to provide for our patients the best care possible. The other thing, knowing we don't know what with our government where things are going to lie, and knowing the district projects, and I've heard they may be renewed, they may not, and understanding there's some projects that really have been impactful for our community. And have you thought about any terms of planning? How do you sustain these programs for the continuum of care? So has that planning been taking place at your clinics?
It has, based on expectations, though, relative to an extension provided by the Centers for Medicaid and Medicare Services relative to that 1115 waiver program. So we did reduce in our current budget comparative last year from $14 million plus expected down to $10 million with a change, and then have also worked to go ahead and sustain with our relationship with CCC, for example, the access to care aspect of what district brought to us is now coming through our normal payment methodology with CCC for our uninsured and MAP patients at that location. I'd be lying to you if I said we have a concrete plan of $10 million if it wasn't extended. That we have a concrete plan to react and say, what are we going to do with $10 million less? The reality is as we look at that, we're looking to the fact that CMS went ahead and renewed in Florida, which was a similar waiver. And I think that there's a very strong likelihood, given the current administration's perspective on state flexibility through these waiver programs, that it would be renewed.
When was it?
It was renewed, actually it was renewed a year ago, 2016, is when it was summer.
Changes then.
Correct. Well, unequivocally, yes, absolutely.
So just in a matter, because I know there's several important programs that are, especially in behavioral health and women's health, that are really important, valuable to our community, that we would want them to be sustained and continued on, rather than cutting them off. So any way that we can support the continuation of these programs, I believe we'll all support.
Yeah, hopefully it does get extended, but if not, I'm sure we'll be having conversations. Appreciate that.
I don't want us to wait till the last minute. So if we have plans, because we never know what can happen in the future.
So I think you were in a meeting that Carol and I had either late last week or this week in terms of contingency planning on our side. So I didn't know you had our place bugged, Mike. I'm just kidding. So unless there's other questions, I think one of the things I was remiss in doing is that our ability to provide these services directly linked to your stewardship as Board of Managers and your commitment to ensuring those that are the lower resource.
Most vulnerable.
Most vulnerable is true. I tend not to use most vulnerable because I think that vulnerability says something different. This is all about resources from our perspective, and this is about how do you equitably distribute resources within our community. But because of that distribution of resources, they are vulnerable, and so we would not be able to do what we're doing without your support. So thank you so much.
We appreciate you. Thank you.
Thank you for your leadership.
Thank you.
Ben?
Being here, thank y'all, Carolyn.
Thank you.
I'm happy to see that you've hired a new CEO.
Yeah, me too.
I just had to
All right,
Thank you.
right.
Appreciate it.
Thank you very much. Okay, now let's move to item 3, discuss and take appropriate action on policy initiatives proposed by the Central Health Equity Policy Council for calendar year 2018. Megan?
Good evening. I'm Megan Cermak. I am the Senior Healthcare Planner for Health Promotions at Central Health, and I project manage the Central Health Equity Policy Council. We launched the Policy Council in 2015 with the mission of identifying and advancing effective health equity policies for low-income Travis County residents. We have 70 members that represent over 50 organizations here locally. We have 4 policy priorities, and those are the leading causes of preventable death and disability here in Travis County with significant health disparities, and that is tobacco, obesity, diabetes, and HIV. Every year we go through a really rigorous process of trying to identify what our next calendar year's policy initiative is going to be. And so I'm going to present those 3 policies that are under consideration for next calendar year to you all here tonight. Before I do, just a little bit of background. Our first policy initiative was in 2016, and that was to regulate electronic cigarettes. We were able to successfully amend the smoking in public places ordinance in June of this past year.
Nice work.
We are launching an evaluation of that effort, and so I'm going to be able to report back to you all public awareness of the electronic cigarette regulations, compliance, both youth and adult use of electronic cigarettes, youth initiation of electronic cigarettes, and then overall tobacco prevalence. It's a long-term evaluation plan, but I'll be keeping you all apprised as we get more information. Our 2017 calendar year initiative was recess policy within school districts. So that is going to school districts and requiring 20 minutes of unstructured physical activity time per day, and that's in addition to the 135 minutes of required PE time. This policy is pretty specific for elementary school kids and younger. When we first took this on, it was part of our obesity diabetes initiative, but as we got further into the policy research, we found that children who have daily access to recess have improved moods, DHEAS levels, and that results in better behavior in the classroom and ultimately better academic performance.
Increased endorphins.
Yes. Right now, we're targeting the school districts that have the highest percentage of low-income students, and that's defined by participation in the free and reduced lunch program.
I don't want.
We're on track for 2 school districts to adopt the recess policy this school year, and that will result in over 20,000 students having daily access to recess. And then we're also on track for next school year for another 2 school districts to pass the policy.
Which are those?
So it's important to know which school districts already have the policy, and that is AISD, Del Valley, Manor, and Pflugerville. And so the two school districts in Hayes, the two school districts that are on track for this school year are Leander and then Marble Falls. And next school year, we're on track for Elgin, and then weirdly enough, Lago Vista, which does not have a huge population of low-income students, but there was a community petition that was requesting recess policy, so we're just kind of capitalizing on the opportunity. Those are our school districts of priority. Round Rock ISD does not have a high percentage of low-income students. However, the raw numbers of low-income students far surpass other school districts. So we're trying to create a real tipping point here. This has been a pretty heavy lift for us, and we have over 60 volunteer hours on this initiative so far. So now we're in the final processes of identifying our 2018 policy initiative. I think I mentioned before, it's a pretty rigorous process. We have a menu of 60 evidence-based best practice policies that we start with. We convene a research committee, and they take 60 policies down to about 15. And then we convene what we call our panel of experts, and they take 15 policies and identify one policy per indicator, and we combine obesity and diabetes. So those 3 policies are for your consideration tonight. As long as you approve, then they'll be moving on to the consideration for the full policy council when they convene at their annual meeting in December. Those 3 policies, the first one is an HIV clinical opt-out policy, and so this is a policy for healthcare systems. Community Care is a real leader in this. They've already adopted this policy. It requires every time there is a blood draw that blood draw is screened for HIV unless a patient opts out. Community Care would like to kind of take the lead on this initiative with our policy council in conjunction with AIDS Services of Austin, the HIV Planning Council, Austin Public Health, and then DSHS. Those would be like the lead supports from the policy council. The next policy for your consideration is a clean indoor air ordinance in Manor and/or Pflugerville. We received a preview of the demographic report last night during the strategic planning committee and saw that our patients are moving to these surrounding municipalities. And it's a tough pill to swallow knowing those folks will be exposed to secondhand smoke in an indoor air setting. American Heart Association and American Cancer Society both would like to take the lead on this initiative. They would be the face of this effort, and then with our support. The final policy for your consideration is what's called a healthy vending policy. It helps with nutrition guidelines of what's sold in a vending machine. Austin Public Health, American Heart Association, and American Cancer Society are already working in this space. The Central Health Equity Policy Council would fill in where low-income people visit or work and/or with our FQHC partners. If you've been down to the Central Health, Southeast Health and Wellness Center, they have a really great healthy vending machine, but that's in practice. And without policy, we know that over the course of the years, those items will eventually transition out to Snickers and M&Ms.
Right.
And it's difficult for our patients when they receive nutrition, education, and advice from their healthcare provider, and within those same 4 walls are being sold Snickers and M&Ms. So those are the 3 policies for consideration. I'm happy to take any questions.
Sherry.
Okay, so I have questions on each. With the first one on the HIV opt-out, you're saying that Community Care has already implemented this? How does this work? How do the patients know that they have, that they have the opportunity to opt out and that they have to opt out if they do not wish to have this?
I don't exactly know how it's implemented, but essentially I think they're given a form that says every time there's a blood draw, they're notified your blood will be screened for HIV unless you sign this opt-out form.
So at the time of the draw, they're given a form, just like when you go to get your flu vaccine and there's forms and things that you're reading.
That's like $2.
So we're getting some different quotes on this. It is covered by MAP.
Right, that's right.
And
What is covered by MAP?
an HIV screen.
HIV screen.
The screen.
Covered by MAP. However, through private pay insurance, we're getting various amounts of anywhere from $2 to $8,
Is what it would cost the patient.
covered by insurance.
Covered by us.
So
But
it's no
if-
cost, there's no cost to the patient.
Unless, but we see some people who are on sliding fee scale, right?
On sliding fee scale, I will look into the cost for that.
Yeah, I mean, so I'm just saying that we see a spectrum of folks,
Oh,
yes.
I think we have information.
Yeah, I can answer that. So there's no charge if someone's
That's right.
sliding fee scale.
Okay.
Someone activated, it's an outpatient.
Okay.
There's no charge. And we do, when we're presenting to the patient, the recommendations from the Centers for Disease Control and Prevention are that you just provide it as a routine screening.
That's right.
You offer it and you allow the person to decline. They're necessarily, in the state of Texas, you do have to sign it.
Right.
Other states you don't, so we do have them go ahead and sign off on it.
So, and is there a protocol to make sure that the people who are drawing the blood are trained to know to present this
Absolutely.
piece of paper that has to be signed off?
We actually, part of our program is funded through the state of Texas
Okay.
opt-out program.
Yep.
And so they came in and they recently evaluated our program, and we're doing exceptionally well with that.
The second one, which was indoor air quality, what does that mean? What are we talking
The
about?
clean
with this
indoor
one?
air ordinance.
Yes.
So here in Austin,
We have a smoking ordinance.
Smoke free.
so it's same thing, smoking
Okay,
ordinance.
so it's a smoking ordinance. Okay, that's probably, we know what that means if we say smoking ordinance. Okay. Clean indoor air, I'm thinking mold and, all kinds of
Oh,
things
I
that can
see.
affect your indoor air quality, right?
Allergens,
Yeah, allergens, molds,
Mold.
mold in the.
black mold.
Yep, all kinds of things. All right, so we're talking the same smoking ordinance that we have here,
In Manor or Pflugerville.
and the same one as in Austin. And then the third one was the vending machine.
Healthy
and-
vending
Healthy
policy.
vending, and you said there's already some folks working on that. What are they doing that's already working on it? What would this mean? I know that, I know what the HIV opt-out means now. I understand the smoking ordinance because it's the same as what we have. What is this vending option? What kind of policy would it be? Is it an ordinance? Would it be just in Austin? Would it be elsewhere?
So it's
talking
generally
about?
worksite policy. Austin Public Health has taken the lead on this here locally, and they've used a government worksite policy model.
Okay.
Essentially, it
Let's see.
sets, I'm sorry?
Bless you.
No, it's
Oh.
somebody's-
East.
No worries.
Well, air quality.
So they use a government worksite model, and it essentially sets nutritional standards for what could be sold on site. So there's a spectrum. You can apply this policy to what's being served in healthy meetings, in meetings. You can have a healthy catering policy. We're
Right.
talking specifically about what's being sold in vending machines, because that's
Yes.
what really the people we serve have access to.
The vending machines, but this is not an ordinance. This is.
It's not an ordinance.
Okay, this is requesting that employers on their own do this,
Correct.
okay? Last question. You were talking about the Lago Vista School District. You may not know the answer to this, but Jonestown, is Jonestown, is that in Leander School District? Do we know where Jonestown fits in?
I know that it's in Travis County.
It
but
is in
I
Travis
think it's, isn't it Lago Vista?
It may be.
Lake Travis.
I don't know.
I think it's because it's right there in that same section.
And it's extremely low income, just FYI.
We have a clinic there, I think.
Okay, thank you.
Are you recommending that we take a look at Jonestown
Yes.
ISD? Okay.
Well, I don't know. I'm recommending that you look at where Jonestown, which ISD Jonestown is in.
Okay.
People who live in Jonestown.
I actually
which
have a map right here that outlines.
I should know the answer to this, but I can't remember. Yeah, it might be split. Yeah, that's what I was trying to, so it is, that's why I said Leander, Lago Vista, it is both.
It is both.
So this may have been why Lago Vista requested.
Okay. Interestingly enough, okay, so there's a Johnson City ISD.
Yeah, no, this is
Right.
Jonestown.
Jonestown.
I'm not talking about Johnson
Jonestown
City.
is-
I'm talking
it's
about
in it's in
Jonestown
Travis
in Travis
County.
County, and it's very
Travis
low
County.
income.
Okay.
And it's in that neck of the woods.
Let's move on. Cynthia,
Okay, so my question was this. I noticed that you were naming some counties, some cities or municipalities that are located outside Travis County.
Oh, all of the school districts that we're working in have schools within Travis County.
Okay, that's why you're naming them.
Yes.
Okay. And then with respect to the smoke-free targeting of Manor and Pflugerville, is that because they are municipalities and Del Valley doesn't have a municipality?
So this is a difficult question.
That, I was just questioning, because we have a lot of little communities that are actually incorporated within Travis County, and I was wondering why just these, because it was what, the increase in numbers?
They essentially have a city
Population?
council that has the ability to
Ordinance.
Well,
adopt an
that's what I'm
ordinance.
saying, it's
Yes.
incorporated.
Right, you're right.
Did that answer your question?
Yeah, that's why I wanted just clarification, because they're incorporated. That means they do
Yes.
have a city council.
Have a
that's
city
elected.
council, yes.
That's right. They're not a village.
Right.
Thank you. And with respect to the vending machines, is that, I know that's just we hope you as an employer will do this for your employees and the general public good, general welfare. But are you going to be checking on the governmental agencies and the school districts also?
So that's where Austin Public Health is taking the lead. And so we'll be providing support to them, per their request. And they're actually going to be the ones training our policy council members on this specific policy implementation.
And the policy council is going to select one of these initiatives
That's
to
right.
focus on.
That's right.
So.
I got that.
could
Thank
be
you.
Any of those. I think Clark wants to make a motion real quick, and then I'm going to come to
Go
you,
ahead.
Ron.
I think all three of these are good projects, and I move that the board approve the proposed policy initiatives as presented by the Central Health Equity Policy Council
Second,
for calendar year 2018.
go for it.
Thanks.
Okay. So we have a motion and a second. Maram?
This is one of my little babies. I appreciate the work that you have done past couples, well, it's been a while, since 2015, that you've worked on these policies. Where I feel the biggest impact for our community might be the opt-out HIV, and I feel we have a lot of resources and support with this initiative in knowing that infectious disease is rising in our amongst our underserved community. Now, the concern that I slightly may have, and I hope that we can address it, like once a patient is identified with being HIV positive, are they going to be on treatment, or if they're at risk, are we going to be providing PrEP for these patients? And because, as we know, it prolongs life, and they can live a really healthy, vibrant life once they are on treatment, and they can. So I was wondering, do we have that into play? Is it? So I don't know who can comment.
Me or?
Whoever can.
Well, I'm going to refer to, there is a very specific protocol when somebody is diagnosed with HIV,
Right.
and the people who are working on this initiative are the folks who are subject matter experts. So, as I mentioned, AIDS Services of Austin, the HIV Planning Council, Austin Public Health, and DSHS are all the ones championing this policy moving forward. And so they're very aware of the protocols that go in place with implementation of the policy.
So that's wonderful to know. So once the patient is identified, I believe with identifying them and being on treatment, it can save lives and save money as well, as we know the health impacts and cost of someone who is HIV plus and transitions into AIDS. So I feel compelled, like this is a really great initiative that we should really focus on, and I know you're going to be now selecting with your committee. Now, I know that as a policy, as a board, we have not allocated any funding. Well, we've allocated some funding, but additional funding for the people to support, for instance, the recess ordinance that you have in place. Some communities are underserved and they may not have a safe playground. So have you thought about the process of linking them to services for these school districts?
Actually, that's been one of our biggest
Alright.
lessons learned of working with Leander ISD. They actually received a grant from the Dairy Council for $89,000 for recess equipment. So we've been able to link that contact with the other school districts. And on a side note, I volunteered for the Del Valley Shack. They've already had their recess policy in place, and so I was able to make this connection and to help with the implementation of their recess policy. So
That's wonderful to know that there's the impact, how it really ripples into something greater. It's not just we're proposing policies.
right, and we've also created a new partnership with the Marathon Kids. They're very interested in this policy initiative, so they're kind of coming on board as our cadre of resources.
Right.
And I love the evaluation component that you have in place, that at least we can measure and see our progress, what we are doing. Thank you.
Any other questions, discussion? Perfect. We have a motion and a second. Thank you. All in favor?
Aye.
Any opposed? Any abstentions? Great work. Thank you. We look forward to
work,
hearing
Megan.
a follow-up. Okay, the next thing that we're going to do is go into closed session. We've got, well, we have one item that we need to discuss. We may get an update on a couple others. But I'm going to announce that we go into closed session. And we have some dinner next door, so we can go very quickly.
Gonna go into closed session in the other room?
No, I think we can stay in here.
Like stay in here?
Not- You're just staying here. We'll stay in
Okay,
here.
we're gonna stay
Yeah,
in
we'll
here.
stay in here. So go quickly next door, get some dinner, and then come back. So, all right, we're going to take up item 10, discuss and take appropriate action on update regarding Sendero health plans, including the effect of federal legislative and regulatory actions. Item 9, discuss and take appropriate action on the 1115 Medicaid waiver delivery system reform incentive payment projects, the Community Care Collaborative, including healthcare delivery arrangements and other interrelated community partnerships. And item 8, discuss and take appropriate action on Central Health owned property, including the downtown campus and adjacent properties. I'm going to announce that the board is convening an executive session to discuss item 8 under section 551.071 of the Texas Government Code, consultation with attorney, under section 551.072 of the Texas Government Code, deliberation regarding real property, and items 9 and 10 under section 551.085 of the Texas Government Code, deliberation of governing board of certain providers of healthcare services. It is 6:34. Let's come back at 6:45 sharp.
And let's correct the time on the clock.
Is it incorrect?
Yes.
Depends which one you look at.
Oh,
All right.
Thank you.
All right, quickly. All right, it is 8:08, and we are out of executive session. We do need to take action on one item. Item 10, discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. I'd like to make a motion. I move that the board direct the Central Health President and CEO to transfer $6 million from the Central Health Contingency Reserve Fund to the Sendero Risk-Based Capital Reserve Fund. Do I have a second?
Second. Thank you, Dr. Bill.
Do we have any discussion? Questions? Thoughts? Okay, all in favor?
Aye.
All opposed? Any abstentions? Okay, excellent. Now we'll move on to Holly. Discuss and take appropriate action on an amendment to the Travis County Healthcare District compliance policies and the Travis County Healthcare District purchasing policies.
Sick, so if my voice cracks on you, that's probably why.
It's going around that table over there. Don't anyone go over there.
Don't cough. Put a mask on.
So the first policy I want to talk about tonight is the conflict and duality of interest policy. We discussed that briefly at the last Board of Managers meeting, and this time I'm bringing you back some suggested procedures that we could add and would like your feedback here in this setting. I guess I don't have to rely on you, Emily. I can click on this. So in the proposed policy, I suggest that we incorporate the requirements of the 2 chapters in the local government code that apply to conflict of interest, regulate duality of interest and self-interest. We define what those words mean, and we include examples of what a conflict or duality of interest might look like. Here is a proposed definition for duality. I'm not going to read it to save my voice. Hopefully all of you can see it.
Oh, we saw that last time you presented.
This is actually direct from something that I wrote. So,
Oh, okay.
Is that what the law says?
So there's no law on duality.
So we've had it in our compliance policies, but we didn't define it.
So that's a
So
problem.
this is a proposed definition. And I guess let me, so here's what I asked Holly to do tonight, and here's what I'd like us to do. So Holly got some feedback, very limited feedback. Now Charles and I are winning the feedback. Did you get feedback at some point? Yeah, so Charles and I are winning. So I asked Holly to lay out sort of several of the most, significant or most noteworthy.
Yeah, so 3 different procedures that we could
Yeah.
follow to deal with
She-
conflict and duality.
She laid out for us last
Right.
time other similar district policies.
Right.
And so I said, kind of put something in front of us that we can nod our heads at or shake our heads at.
Right.
So then in December, she could come back with a draft policy. Because I don't think we've given her enough direction to actually put something in black and white in front of us.
Got it.
So it's sort of like, do we want this definition or something similar?
She needs feedback.
Will we get this in print?
Yes, you can get this in print. I will make sure all of you have a copy by the end of this meeting.
But because I know how we work, meaning very few of us get back to Holly, I'd like us to give her feedback in this room so she can bring us something in black and white in December. Otherwise, we're never going to get this done.
That's why I like something in front of me.
I understand. So this is just one possible
Do you
definition.
have anything right now that can be printed? This presentation can be printed? I'd like that right now.
Yeah, Emily will print it.
Thank you.
Another definition that I thought was useful here was self-interest. And so here's my proposed definition of self-interest.
Is there a reason that we have to have that definition?
We don't have to have anything other than conflict of interest, but I believe the board had expressed a desire to have a duality of interest definition, and self-interest is a type of duality of interest.
the word self-interest was used in the duality definition. So she's defining it because it was used in the other definition. Is that correct, Holly?
Correct. Okay, so the rest of this is not actually definitions, it's just proposed policy procedures that we can implement. So the first one is something that Mike and I discussed, and that is the chairperson would read a reminder statement at the beginning of each meeting that we all have fiduciary obligations to Central Health, and if there is a conflict, we need to disclose that. And then each board member would have an opportunity at the end of that statement to announce what they believe may be a conflict or duality of interest at that meeting. And other board members would have the opportunity throughout the meeting to act as a check. So if they think someone is participating when they shouldn't be, they would have the opportunity to raise that concern. So that's one possible avenue.
Can we, or do
You have
we-
other
Let her
options?
Let's go through the presentation,
options,
then I
yeah.
want to go back to the beginning, because I want to
Okay.
talk about some stuff too.
So another possible option, which Clark voiced in the meeting from last month, is that board members seek an opinion directly from legal counsel. And I know, Cynthia, you asked about, is it always the Travis County Attorney's Office, or could we use someone else? And the answer to that is yes, to both. The opinion is going to be confidential, at least in my proposal, but it doesn't have to be if you don't like that, unless a violation of the policy is alleged. And legal counsel will tell you what the appropriate course of action is before the meeting, so you know whether or not it's appropriate to participate in discussion or take a vote. This is very similar to the University Health Systems policy that I provided you.
That's Bear County.
Yes. Another option is that the board determines whether an individual board member has a conflict or duality of interest by a majority vote. The last option that I came up with was based on
Kindergarten.
Dr. Bell's recommendation, which is a non-board committee consisting of legal counsel and a compliance officer would determine whether a conflict or duality of interest exists, and they would provide recommendations on appropriate course of action, which is very similar to how the El Paso County Hospital District handles this. All recommendations would be made public, so the entire board is aware of the conflict and what the remedy is. And then
Great. Can we go back to, can we go through it again and kind of give you, so I like the definition of duality.
Let's get to
We
it.
get some feedback and wordsmithing on it, but I like having a definition, and I think that's a reasonable starting point.
Well, I will say, I agree. If we're going to have it, it needs to be defined. It's not very useful to us
That's right.
to have something and not have it defined, which is the situation we're in today. So,
And if I'd like, in following up on that, if I see something there that I'd like to have defined, then I want to go to whoever's considered the experts in ethics and conflict and look to see what they have as a definition.
Well, and that's
Just
what
as a
we've
comparison.
done is
that's what we've done, is looked at other,
Oh, no, she used hospital districts. Did you go to what exists in the world with respect to?
many nonprofits and how they treat conflicts of interest. I only presented to you what other hospital districts were doing.
That's right. That's what I
But
thought.
actually, the third option I presented to you, which is the board by majority vote decides, is very similar to how nonprofits handle. Once a conflict is disclosed, the board decides whether that person has a self-interest and must recuse
I
themselves.
think I heard several groans when you got to that one.
I know.
So here's what I would propose, that you incorporate that definition. We may, and then you'll circulate a draft to us in advance of the next meeting.
I will.
So if some folks want to mark up or send you proposed alternative language, we can consider that as well. But I think defining duality is a good starting place, and I'd like to see it, and I'm actually fine with that language. I don't know if anyone else.
I am fine.
I just like to compare, that's all.
Yeah, I'm fine with it. But you'll have examples, correct?
I will include examples in the policy I bring to you before the next meeting so that you can see the types of things that, at least I think, constitute a duality of interest.
For
And then,
instance, involvement.
what does that mean?
It's clear financial, but sometimes the involvement piece, what does it mean in terms of duality?
I think this is when I asked, like, we have staff people that are volunteers or board of managers that are volunteers for an entity, and the next thing we know, it ends up being funded by us. okay?
So actually, Dr. Ballard.
That is and
No, but.
will happen. I mean, it absolutely should happen.
Well, no.
And we don't want people on this board or
I
working here
understand,
who.
I understand that, but that looks to me like a conflict.
No, so that's why.
To me, that's what it looks like.
I think,
That's not a conflict.
Well,
I
I
think it should be-
understand.
if you're concerned about it at the time, whatever process we set up, it should go through that process. Okay? So in essence, if you're a volunteer and you're concerned that your involvement in an organization constitutes a conflict for you, or duality, or self-interest, then that would come up and
Okay.
it would be examined on however we decide we
No,
want.
I understand, but yeah, I'm not speaking in terms of myself or you or anybody else here. What if I say, oh, Maram has it, I think she has a conflict. And so do I bring this up at the beginning of our board meeting as we're being televised?
That's what we're talking about right now.
As we're being
That's what we're
televised?
talking about.
That's what we're
Cynthia.
talking
We have a menu of options.
So when we look at that, I'm gonna take all of this into consideration. So,
Yeah,
We all
we have
are.
a menu
And
of
all of
options.
us are taking all
no,
of that.
no, I understand.
Okay, can we move on from duality?
Yes, at least I do. I'm okay with moving on.
Yes.
Please.
When is the definition of self-interest used? Where does it come up?
Yeah, it's not used in duality. I thought it was.
So, actually, the way that I defined duality in my version, it would have a sentence that says duality includes self-interest, but I was trying to limit the number of words per slide. But duality and self-interest, to me, self-interest is a type of duality. That's how I
Okay.
view it.
So it's a subtype.
I'm equivocal on self-interest. Having a definition. It could go either way.
Or not. That.
Okay, so we've got
you
a
know,
question mark on that one, I think.
Okay?
Yeah, and object, when is it objective and subjective, and, because it's in each individual's definition or
Yeah,
perspective.
we're not gonna completely erase
Yeah.
subjectivity.
Yeah.
That's right.
Okay, now we're on to our menu, right?
I like the reminder statement.
Chairperson, I like that.
I like announcing your conflict. I mean, so with that, each board member announces a possible conflict. Like what we do now is we typically do that at the time we vote. Is
Right.
that when
That's
we
right.
do that?
We could do it either way. We could do it initially after the statement is read, or we can take it up at the time an item is read. In my mind, it might be easier to do it immediately after the statement, so we're all able to keep a check on each other. If we
I would say
forget-
on item 3, I have a conflict or I have an issue of duality and I'm gonna recuse myself or I'm gonna not vote or.
That's a possibility. I was thinking more along the lines of, I'll possibly have a potential conflict tonight. And then when we get to the item 3, like we've normally done, we disclose that at that time.
I like the idea of doing it at the item time, because there are board members who come in late or leave early, and sometimes they're not even here when that item is discussed. So if we're here when that particular item is discussed, I think it's appropriate at that time for the board member to disclose that.
Yeah, I agree
I
with
think that's a great point.
I agree with that.
Yeah.
What about the other board member acts as a check? If somebody,
I don't like that at all.
well, but I think,
Sorry,
well, but I
I
think,
don't.
I already checked on me.
Checked.
How does that work? Can you
Yeah.
explain
So I
that?
think if somebody has a concern that, you know, if you say you still worked as an ACA enrollment counselor,
That's right.
if I said, well, Cynthia, I don't know if you should be voting on this contract to go to this entity that you worked for. I mean, I probably wouldn't put it that way. What I would say is, Cynthia, do you have a conflict on this item that
I say, no, of
you
course
say
not.
no? And all
I'm
of us
the
would
least
knowingly
conflicted-
look at each other.
I'm the least conflicted person here. What are you talking about?
I mean, I think that's the kind of situation. But so what if we said, Clark, do you have a conflict with your law firm? And you said, actually, we don't do business with that entity anymore. And then we just move on from there. I mean,
No, because Clark has, historically, Clark has always, when we're about to discuss
No,
an
I'm
item,
just using
Clark has
that
always
as an
said,
example.
well, you know, I'm gonna recuse myself or something because I don't know if we have business and
And
it's
most
not
people
me,
have done
blah,
it,
blah, blah.
even when a conflict doesn't exist, they've done it out of a abundance of caution.
That's true.
Sherry?
Don't we have the ability to just do that? Does other board members act as a check? I mean,
Like, we don't have to write it into the
exactly. I
policy,
mean, don't we
somebody
just
can raise it.
have the ability?
I think the question
that?
is this. Let's say I've got a big smoking conflict
Yep,
and I won't admit it. You know that I have a conflict.
right.
And you ask me, and I say, I don't have a conflict. And, okay, so what are you gonna do about it?
That's right. What happened?
Can you
Right.
then say, well, okay, I'd like, I'd either like the rest of the board to decide whether you have a conflict,
This is where we get to amend.
or I'd like for Holly to decide
Right.
that, or I'd like Holly and the compliance officer who's not a board member and not at the county attorney's office to decide that. And if they decide against me,
Right.
then I can't, my vote won't be counted based on this policy. But for that policy, law wouldn't preclude me from voting on that. Or if I'd go ahead and vote, I may have committed a Class B misdemeanor. But, depending upon whether I've, touched that statute. But, so we're either gonna have a policy that says you can call me on my conflict and in essence neutralize my vote if you win and I lose.
But is this
So
committee
unseemly
gonna form on the
to have
spot?
to go through that.
No, I agree with you. I think it is
But
unseemly.
that's the question to me.
Hang
The
on,
answer to all this is we ought to all err
Yes.
on the side of fully disclosing and not participating.
But we may or may not have board members who always do that, I think.
I understand, I
Right.
understand.
And that has
That's,
happened in
but
the
that
past.
to me is the question.
That has happened in the past. And
Cynthia?
And so, my concern is this, because I look to what happened before we ever came on this board. And so when we have a vacancy, and we know that somebody has applied for a vacancy on our board, I check out the application. And sometimes I see applications.
So how,
No,
relate this to this, because we're gonna be here all night.
I am relating it to
Yeah.
this. So let me finish. So as I see that this applicant has checked every single solitary conflict board, check box, every single one. UT, St. David's, Seton, whatever, all the way down. And yet they continue to participate here. At what point
Yeah, what-
do we as a board know what the extent, what that means? What does that conflict box mean, and how does it relate to this? So when we're acting as a check, am I gonna have to ask everybody
Is that county?
this?
Yeah, I don't remember seeing that, must be a
There
county.
is some-
It is.
It's the county.
It is.
So here is what we're talking
And
about
at the
now.
city, we don't know that at all.
So here's what we're talking about now.
And that is
How do
what
we-
we're talking about.
How do we deal with this as a board?
Right.
So,
That's right. So when we first come on the board, is everybody supposed to disclose exactly? Do we
So-
ask them, so what are your conflicts?
so listen, so we have a statutory requirement. We have a statutory requirement around conflicts of interest. Beyond that, it is only our board policy, which we are discussing tonight. So what would you like it to look like is the question right now. So you presented the problem that we're discussing. What would you and you and you and all of us like that to look like? So that's the question. What would you like to do about what you just described?
Well, personally, I think that as we come on our board, and I don't know if this should be done publicly or whether this is something that should be done in private, an executive session before we begin, as we begin the meeting and then we go into executive session, or publicly it doesn't make.
Well, that's what we're talking about, like, so having a reminder at the beginning of each meeting.
So at the beginning, we should, if
When
we're
somebody
going to
first comes
use
on the
this,
board.
if we're gonna use this and we wanna know what a check is, then I would like to know what each board member's, checks are.
So,
Want to be able to see what the board members' relationships are with various entities that
Yes,
we may.
That's right.
with, so
That's
that
exactly right.
They check during.
That's
a
right.
meeting.
Yes.
Otherwise, I wouldn't know.
okay, so are you proposing that at the beginning of each board member's term,
Yes.
that they fill out a
right.
form, I guess similar to what the county does?
Yes.
The county does require
County
that you
makes
do
you
that.
yeah,
Well, what a lot of organizations do is every year,
yes.
That's right.
every board member fills out something that says, I'm aware of our policy, I've read it, and here are the conflicts that I can,
That's right.
that I think, I mean, obviously Seton and the University of Texas are areas that we know of that
St.
we want to
David's.
look at, and if you have a conflict there, you'd want to describe that in some
Or
amount
medical
of detail.
providers.
I've not seen the.
That helps the staff, I
Yeah.
think, know.
So the.
It's like a 16-page county.
Well, that's the financial.
But
City
every
staff
year,
has
it
to
shouldn't
notice
just
every
be
year
when
too,
I get
City of
appointed.
Austin
It should
staff.
be every year, I should have to update
Yep,
that.
and City
That's right.
Austin staff has to do
These
this
things
every year.
change.
So why don't we have, can we have a draft that's based on the county model that just talks about conflicts? I don't know what the whole application is. We don't,
Yeah.
if you already applied to be on the board, you're
It
on the
has the
board.
boxes
It
that
does.
you check for
It
conflicts.
does, it does.
And we could maybe do that annually?
Yeah,
Yeah,
I think that's a
because
great
things change.
idea.
Yeah.
Most of the policies that were sent to you included an annual.
Right, they did.
Recertification.
Okay.
I like that. So if we're going to do that, then we need to be made aware.
So I heard, just to recap, that you like the reminder statement, you like the announcement, but you'd like the announcement to be at the time the item is brought, not at the beginning of the meeting. And that we're kind of iffy on other board members act as check, but if we decide
I
on
don't think we
that.
can stop a board member
Yeah, my
from
point is you
speaking
can't
up.
stop them.
No, you can't.
That was
But-
my point.
But if we're going to do that, then we need to know what they are.
We need to know
It's not
that
a
next
policy.
menu of options.
Okay.
The if-then.
I mean, does that first bullet sort of exists now?
Yes,
Yeah.
Yes,
it does exist.
yes, that
Should
exists.
we just codify or, memorialize it in our,
Well, if it's there.
so we're writing the policy.
I think the first bullet, we're always here to answer your questions about whether you have a conflict or duality. The second bullet is where you're going to see the change, because we might advise you, we think that you have a conflict, we would advise that you do not actually participate, but it's still up to you. Under this, and I didn't put that up there, but I would imagine that legal counsel, once they make a determination, you have to follow the recommendation.
And who knows of that except the person that you're talking to?
Well, it's
So I mean, does the
attorney-client
chair
privilege,
know
yeah.
it? Do the rest of the board members know what the remedy is? Or is it just me if I have the conflict?
It's, again, whatever, if you would like the entire board to know, I can draft it that
No,
way. If you
Do
want
we have
to-
a compliance function at the executive committee? Is that where our compliance function resides? So I guess if you thought Clark had his big conflict he was discussing, and he didn't disclose it, and we thought he talked to Holly, and Holly probably told him, you ought not participate in this, we could make a complaint to the compliance committee, who
Well-
could then
But I
But
believe,
we'd have to know who is the compliance.
So it's a function of the executive committee. So,
Of the board.
right.
but I believe if there's an action
It's
made,
in our bylaws.
it should be transparent to everyone on the board. It could be, the legal counsel could be in, confidential, let's say if I have a concern, but if you directed me not to participate, I think that should be.
Yeah.
That would be the legal counsel.
Yeah,
So-
legal counsel
So where, are you
determines.
talking about making that public or not making it public?
Making it
Make it
public.
public.
If it is advised.
So then you'd
it
be
should
making
made
the
public.
legal opinion public.
But the opinion can be confidential, like I can.
That is
probably-
the opinion.
No, it has
No.
to be, you
That
want
would
it to
be
be
the
public.
opinion.
Two bullet dots up
The
there.
council
Are you
two.
gonna do one and two or just one?
The first one can be confidential.
I
If I
don't see
have
a
a
distinction.
Consultation.
consult, exactly.
So I'm
Yeah.
consulting the
Right.
legal counsel.
That's-
And she may say, don't worry about it. And then that was confidential, my consultation.
Okay.
But if she says, yes, that's a conflict, and this is what we think you should
Right.
do.
We should all know about it.
That has to
That
become
should be-
public.
Okay, I just don't see a distinction. It sounds like it would.
The
always be-
violation or the proposed violation becomes what should be made public.
Well,
I would maybe draft a written opinion saying, here's why I think you do or do not have a conflict. That written opinion, in my mind, would be confidential. But the existence of a conflict at a meeting, if that person decided to vote, it would not be I would say, I've told you you've had a conflict.
Yes.
So that person would then have the right to say, well, I challenge your opinion. And then what happens?
Not under this policy. If
Well,
we
no,
go
but
with
I
both
would want,
bullet dots,
I would want to see that because I would want to know
I
that.
want to challenge.
you would have
You
known
don't
that in
know.
your consultation.
You have no, I'm offering all the options.
Okay, so we have two separate bullet points up there. And you can do just one or you can do two. If you do just one, board member seeks an opinion from legal counsel prior to board meetings. Opinion is confidential unless a violation of the policy is alleged. You just, you do that, and if there's no violation, nobody knows.
Exactly.
That's correct.
If there is, opinion is confidential unless a violation of policy is alleged. If the violation of the policy is alleged, then number 2 kicks in. Legal counsel has determined that there's a conflict or duality of interest, and that is going to become public. And you could write the first bullet dot without saying opinion, you could just say opinion is confidential. Okay? You could do that. But once you add on there, opinion is confidential unless the violation of the policy is alleged, then you're basically kicking in number 2, which means legal counsel is making a determination, and that determination, if it's a yes, there is a conflict, it's going to be public. Is that correct?
That's correct.
But it's going to be made public before the conversation ever occurs. Because
No,
we're.
No.
have to consult them
You have to do bullet dot 1 first.
No, I know, but you won't know whether they're going to act unless we have gotten to that item on the agenda and we're having a discussion. So if we're going to have a discussion and that person is going to participate, legal counsel will know that. At that point, legal counsel can tell you, I think that we have a problem here, basically. Because it doesn't happen
You're
after the
supposed to have
fact.
consulted them in advance, though.
No, you can do the consultation in advance, but the action, the fact that if they are going to, they have been consulted, they have written, you've done whatever, but we're going to discuss this, and we have had board members that say, well, I know I'm not supposed to participate, but I'm going to say something anyway, okay? That has happened in the past.
Right.
I think that's what
Okay.
Sherry's saying, is when that happens in the heat of the moment, when
And-
we're at the
And
item.
the attorney says or doesn't say something
You
at
would
that
say
time.
She would say something.
Well, I'm glad, because
How about we draft it that
happened
way?
Yes.
doesn't.
And if we want to,
Predecessor didn't.
It wasn't the policy at the time.
Okay,
right, we're
so
adopting a
you'll
policy.
clarify it.
That's what this is about.
And so,
Draft it and read it.
Yeah,
Yeah,
you'll
that's
draft what we just
Okay.
discussed. Okay.
right,
So this is the one that I think no one liked.
Yeah, I think we didn't
Yeah.
like that.
Yeah, like-
So, last one.
I think the slide before, the 2 slides ago took care of that.
It's very similar.
Yeah.
We
But
basically
it's,
set up a
you
process.
can't do
You
both.
You just
It's either
added,
or.
yeah,
Yeah.
all you added was a committee
Yeah,
as opposed to the legal counsel.
exactly. These are, you don't do both these, it's either or. It's just gonna be legal counsel, that other one with the 2 bullet dots, or you do this one instead, which is you have a non-board committee, and it's going to consist of, you were saying maybe legal counsel, compliance officer, and somebody else.
I'm fine putting the heat on Holly and Nicole
yeah.
and taking
that's
it off us.
Let them take care of it.
So,
And so I have one more question. Now, these things here, aside from 170, these are covered, everything we're having a discussion about is actually covered in 171 and 176.
We're going beyond that.
So why are we going beyond that?
So, I think what Katrina was trying to explain earlier was our policy currently includes both conflict of interest and duality. Duality is actually not defined in either Chapter 171 or Chapter 176. So I'm trying to provide a definition for you and help you with those kind of messy, non-financial situations, because 171 and 176 only regulate financial conflicts. So if you receive compensation or you have an ownership interest in,
It doesn't go as far as some of the things that you've expressed distress over.
Right, it doesn't cover them.
Moram.
so we're only talking about current members, board members.
It's a policy,
everything.
it's a board
So what about
policy.
future board
They
members?
would have to
Well,
adhere.
yeah, our board policy.
So let's say right now
We're writing
there's,
policy for everybody.
well,
Future.
giving into right now, a new appointment is gonna happen with the Travis County. So let's say,
When they change the speed limit on the street, it applies to everyone driving
Everybody.
on the street
That's right.
then and in the future.
That's right.
We're changing the speed
Absolutely
limit.
right. A policy's a policy.
That's the way it works.
And of course, the policies can be amended
we
as
can
we
change
try
it.
But
to-
unless we
Right.
change it, then that's the
In
policy.
2 months, we may decide,
We're making up the rules for ourselves. How do we want to conduct business around these
Which is,
discussed?
which is typical for legislative bodies. So if you're in the legislature of the state of Texas, the members of the House adopt
rules.
the rules about how they're going to conduct themselves, and the members of the Senate do the thing.
their own
They make
rules.
up the rules and they vote on them, and everybody, even if when you come in new, you have to adhere to those.
that's right.
This is typical of a legislative body.
And if we try it and it doesn't work and we don't
And you
like it,
change
we can
yeah.
modify
It's
it.
like the Texas House of Syndicate.
understand, my question was, let's say they elect or they recommend a person who we know has a conflict of interest with us.
They have
They'd
to
be
disclose
subject-
it. They have to go through this
So
process.
listen, that happens.
Yeah.
We do, I mean, that's
So
what
we don't have
chapter,
control over what decision
Oh,
they
we
make.
have no
that's
control
what,
over
that's
their
what chapter
appointments.
171 is about. It doesn't
right.
mean if you have a conflict
Right.
of interest, you can't participate on this board.
That's right.
That's
You
right.
just need to take certain actions around certain items.
Correct. It may mean you can't vote on a certain budget item, for instance,
That's right. That's right. But
or
with-
shouldn't, and in the future.
That's true. So with respect to this also, and one of the things that I did bring up in the previous conversation was the practice. So if you have a conflict, you can still be seated in the room and listen to the discussion. You just cannot participate in the discussion of the vote. But you can be there. You do not have to leave the room, and we should not be asking any board member to leave the room. That's what I have to say.
And you're right, the Attorney General has a.
Yeah,
No.
and I disagree too.
Yeah.
Okay, so do you have enough direction?
Well, Clark and I agree.
Take a stab at
Yeah.
sending something back to us?
I think so.
Oh,
I would like to hear though, would you prefer just
Better
legal
than they would.
counsel, or would you prefer a legal counsel and someone
Watch
else
it on television.
on this non-board committee?
I think you heard, we want to put you guys on the spot.
Yeah, legal counsel.
That's right.
Now, the other distinction was all recommendations would be made public under this one. On your prior one with the 2 bullet dots, it just said if you determine there's a conflict, it would be made public, right? Isn't that a difference?
Public to the board or?
To the board.
Yeah.
Or which would be the
Public.
public?
Public to the public.
Public
Because
is the
we're going to be
meeting.
televising our meetings. So it's to the public.
The way that this is written, and Dr. Bell, you can correct me if I'm wrong, I believe you wanted all recommendations. Anytime that someone came to me, I told you yes or no, they didn't have a conflict.
Yeah, so that's different from
That is
the one a
different
couple
from the
pages
first.
back.
That's right.
Because that one said,
Only if
opinion is
there's a conflict.
confidential unless a violation of the policy is alleged. So that is different.
Holly, could I ask you a question?
Sure,
These are going to be policies, not in our bylaws.
that's correct.
That's right.
Let's go back to this Hydrick guy who's got this glaring conflict. And let's just say that Maram, being a highly ethical person, calls me on it, and we submit it to you, and you say that you think I have a conflict. And I guess you say I should not vote. I don't know whether you formed a legal opinion yet on this, but I mean, would my vote then not count if I just decided to pay no attention to you? Could you, in essence, keep somebody who got appointed by Travis County to be on this board, say to me that I can't vote on that?
So I think there's some First Amendment issues around not being able to vote, but maybe there's a way we can say, we won't count your vote. You can vote, but we're not going
Well,
to.
I understand
But
that.
that's the same difference.
But you won't count my
It is
vote.
the same difference.
So are you comfortable that a board policy can, in essence, control that legally? I would hope that that's the case, but I don't know.
Because all these others have done it. Is that,
I mean, none of the policies say if you vote anyway, regardless, we're not going to count your vote. It's not been that specific.
right?
But if we count your vote, the entire action of the board is jeopardized.
That's correct.
So I think we have legal authority to say, if
Doesn't
you
count.
vote, we're not counting it.
Okay.
What about a different scenario? We had a vote, We had about 5. And then after the vote, we found out there was a conflict of interest. So what would happen to that vote?
You don't have to have a quorum of the board vote
Right.
for a vote to count.
What is it? We don't?
Just a majority of the members present
For what?
for a vote.
Your
No.
question is that if the vote has a legal.
It's already occurred.
It makes the difference between winning, losing, or tying.
Well, no, you can't have a vote unless there's a quorum present. That's the first and foremost. You cannot have a vote unless there's a quorum present.
Okay, so here's,
You can't, that's it, bottom line.
So
Next meeting.
I would prefer to answer this question
Yeah.
in the closed session environment.
Okay,
That particular question about what would happen if
Okay.
we had a conflict.
so let's tee that up
That's
for
why
a
I
closed
said,
session.
are we gonna have these in public? Are we gonna have these in closed session?
He's just saying.
No, this
now.
particular
Okay.
legal
Oh,
question
this.
is
So let's-
to be an executive session.
Okay.
let's see the next draft
Yep.
and we'll
And can we
continue
take up-
having this
But
conversation.
it sounds like we may need to take up the next draft in closed session because
right.
there are attorney-client issues that fall under that.
I know that Cheryl and Nicole are looking over there at Robert's rules to see what does Robert's rules say about not counting a vote.
Right, so,
Okay.
okay.
All right,
we
so
need
more to
take
come
this
on
up in
that.
executive session.
Right.
You have enough direction to get us to the next step?
Yes.
Thank you.
Thank you very much.
So just
Can-
like maybe 3 more minutes is
Okay.
all I need of your time, and that is related to the purchasing policies. And so, as many of you know, the Travis County Commissioners Court adopted new financial policies for Central Health. And
Right.
one of the provisions of those financial policies states that the Central Health Board of Managers will adopt a policy on intellectual property by December 31st, 2017,
Which is,
which is coming up, or on January 1st, we will insert provisions similar to what the county uses in their contracts in all of
or
our.
IP, for intellectual property.
So
We're gonna get that draft?
what I would like to do is similar to what we did on this exercise, which is send you some sample policies.
Good idea.
Send you some procedures, but because we're on such a tight time frame, I'm going to need feedback before the meeting so that we can actually get you a written policy.
It's fair enough.
Cynthia?
I did send you a question that I had and a concern that I wanted to be discussed during this development of this policy when it comes to respect, to conflict or duality or self-interest or whatever, and that was the development or incorporation of revolving door language. So we have somebody walk away from the board, or we have somebody walk away from staff, and then the next week, they're here applying to be a contractor for us. I think that is as important an issue that needs to be incorporated into this. I asked, and I sent that to you in an email.
You did send that to me.
So you didn't respond to it.
I actually did. I remember we said I would talk to you after the meeting, which is today.
Well, we're talking here, okay?
I'm happy to kind of hear your thoughts on what a revolving policy.
Well, I just said, somebody walks away from here as a board member or a staff person and comes back the next week and wants to be considered as a contractor. And then they put in applications for RFPs, RFQs, whatever, purchasing policies, whatever.
Okay.
And
I'm
so
gonna-
I want that to be included also.
Sherry?
So, I understand what you're asking for. I would suggest a couple things. One, look at, do others have this?
We've looked at this,
The city has it.
I'm just making a
we
list
talked
of,
about this in the not too distant past.
The last time I brought it up.
so, do others,
Take a look at whether other hospital districts and other similar
yes, entities,
have
City does.
they're
revolving door policy.
somewhat different entity, but whatever. Yes,
Governmental agency.
it is. Whether they have it, and if so, what it is, because to just do a blanket of all employees
No, I agree.
and have, staff
Okay.
has huge repercussions.
Okay,
and
so
I'm just
here's
gonna
what I
leave it at
propose.
that.
Let's focus on the policy that we've been working on.
agree.
Let's
We have to
see
do the
some examples or something kind of in the fashion that you did for the conflicts of interest duality policy. I don't want to slow that down, but we can look at this in a parallel fashion. How about that?
And I would just add that I think the policies we're discussing today, are the board policies for active board members, not people who've rotated off, but maybe
Right.
there's room for what you're talking about in the purchasing policies.
Right.
Well,
Right.
that's,
That's where that would fit.
What
Well,
we're doing
I don't
is
think,
taking
I
us
don't
long
see it
enough.
as being a slowdown. I think it's
It's just, it's a
necessary.
separate issue, so, so I really do
It's a
wanna,
new issue,
We're
just
gonna
like
be here all
this is a
night.
new issue. They're both new.
it's actually not that new, we've been talking about it several times.
And I have brought it up
Let's-
every time.
Okay,
I've
Let's
had an
keep-
opportunity.
Can I make sure I'm not confused?
Okay.
So what I
Like to
think I
clarify.
heard was that Holly has good direction from us on this, and she's going to get us another draft. That's number one. Number two, she's gonna look very quickly, because time is of the essence, at what the county and some other hospital districts, let's say, have on intellectual property, and get us some language on that we're gonna have to respond on PDQ, because we have a December 31st deadline. And the third was that those two take priority, but also when she, we've got to put priority on those two that she will also then put in the queue to look at this issue of the revolving door and look at some comparable policies. But those other two have to take precedence in the
Well,
queue.
and I appreciate that. Thank you for reiterating that. But the
That's
reason I'm
correct.
saying that is because she said she was gonna respond here.
Okay, and she did,
Okay,
all right,
okay.
let's move on.
I never really quite heard
Let's-
her response.
let's
after
move on.
y'all's.
I'm just trying to make sure I understand. Okay.
All right,
Thank you.
you have what you need, let's move on to item 2. Discuss and take appropriate action on the formation of the nominations subcommittee as described in section 7.3.1B of the Central Health Bylaws, which, I did not revisit. But, my recollection is that, we have the board chair or the immediate past chair serves as the chair of the nominations subcommittee. And then, so that would be me, and then I'm gonna propose a, committee that,
One other note is there also has to be one other member of the executive committee on that.
The two
So
members.
vice president or vice chair, treasurer,
oh, okay.
secretary.
I did not know that before. So we have, me, Pete, Sherry,
And
and Charles. Sherry, how would you like to be on the nominations committee?
She's really excited
So,
and positive.
We're all excited.
all right, so I'm gonna make a motion that, the board approve the formation of the nominations committee and appoint, Katrina Daniel as the chair and managers, Cynthia Valadez, Maram Musatif, did I say that right?
Say TIF.
Right?
Dang it, I'm gonna keep working on it.
Think of TIF treats.
And, oh, that's a good one. And, Sherry Greenberg to serve on the nominations subcommittee.
Second.
Discussion.
I have a discussion.
Yep.
And I think I mentioned it to you. So those who serve on the nomination committee are also eligible to be nominated for any of the, considered for the positions.
That is correct.
Okay, that's just,
Any other questions, comments, discussion? All in favor?
Aye.
Aye.
Any opposed? Thank you, Ms. Greenberg. That's what I get for not going back and reading that.
Thanks for your service, everybody.
It's like when it's cold outside. Do you ask your children, do you want to put your coat on, or do you tell them,
I should have,
you are putting
it.
one of these coats on?
I should have just read it,
Which
you're
one?
right.
I think that's a great committee.
Okay, so let's do the financial statements next. And do you want to do it in a fashion that hits the high points, anomalies, aberrations? Okay, item 5, receive and discuss a report of the September 2017 financial statements for the Community Care Collaborative. And item 6, receive and discuss a report of the September 2017 financial statements for Central Health. These are not year-end, right? Next month we'll get year-end?
This is preliminary year-end.
Okay.
You got them
So-
last month.
So I say this because,
We're gonna hear them.
well, because this is a very, very important function that we do. And I am asking that you sort of hit the high points, because at Budget and Finance, we are going to do year-end numbers that,
So what'll happen is I'm gonna go through the preliminary that we provided, last month.
we didn't have time for.
And then when the audit is completed, we'll have the final,
Okay.
as the audit is completed.
That won't be till,
But at Budget and Finance, I guess what I'm saying is I don't want to give short shrift to this work, because it's important work that this board does.
So at Budget and Finance, we hope to have October financial statements.
Say that again. At
Budget and Finance, we would hope to have October
October.
financials, which
Right,
would be
okay.
first month of the new fiscal year.
Oh, okay. Oh, okay, so this is, we're not going to see year-end
Till
again
January.
until the audit,
Oh.
I see.
on the new,
Okay,
Okay, so, just walking through, again, preliminary. While we don't anticipate significant adjustments, we do have to make sure we get all of the information into the right period, and we do go through a financial audit, which is underway, or beginning, very shortly. And so, that's why they are considered preliminary. So for the CCC, we had, at the end of the fiscal year, September 30th, 2017, cash and cash equivalents of 40.6 million, total assets of 40.9 million. We did have liabilities of 22 million, which had a remaining net assets of, I got it now, of 18 million. Looking at our expenditures through the end of the year, this is the full 12 months of the estimated. And again, information will change. We leave it open a little bit longer. Claims data has a little bit more of a lag with the CCC, but our sources of funds, we estimate at about $153.8 million. Sorry, that's the approved budget. About $139.8 million. We did have member payments from Seton and Central Health, as well as our DSRIP revenue, which are three major sources of revenue. On our uses, we have healthcare delivery of $73.2 million, which I'll go into a little bit more detail. And we had our UT services agreement of $35 million, and the project costs related to the DSRIP program of $17.7 for total expenditures or uses of $125.9 million. Our sources over uses are estimated at about $13.8 million. So looking at the healthcare delivery, which is the largest expenditure, our primary care was at almost $6 million, which is about 90% of our budgeted amount, and our total healthcare delivery was $73.3 million, which was about 77% of the budget. Again, this is our primary care at about 90% of our budget spent, $44.5 million. On our specialty care, we are estimating about $5 million in specialty care expenditures, which was about 47% of what was budgeted. And then we also have continued to break out for you the dental specialty care, behavioral health, and post-acute care. Each of those are highlighted on page 8. With $436,000 in dental specialty care, $8.2 million in behavioral health, and $1.6 million in post-acute care. And then finally, our last section of the expenses in the healthcare delivery is the MAP redesign, and that about $565,000 is our estimate for the year end of that line item. So again, the total healthcare delivery was $73 million, and the total uses of funds for the year, $125.98 million. Yes.
May I ask a question?
yes.
On page 7, for specialty care, 47% of the allocated budget, year-to-date, $4.5 million, at 47%. Is there a chart that talks about each of these things with wait times included, and why have we only expended 47%? And that's gonna be per clinic or per group.
Okay, I would need to produce that chart, but you do have a little more information in the document.
I'll look at that.
Let's get through the whole,
Okay.
report.
Okay, so you would like a chart with each wait time?
We'll go, you wanna continue on?
I'm finished with the CCC. Do
Yeah, she's finished.
you want me to go to Central Health?
Katrina.
Okay.
She's
That's
finished
why I
with the
asked it,
CCC.
because she had
That's a
finished.
good question.
Oh, I thought she was saying we were gonna come to more detail later.
No.
No, I'm just saying there is additional detail which I can read, but you have in your packet.
No, I can read it, but 47% is what I'm seeing, and
And
5 million.
I would just say, I believe John Morgan and Mark Hernandez, Dr. Mark Hernandez, have been coming throughout the year to talk about many of these items.
And I'm talking
and-
about for the end of the year, as we approach the end of the year, and we're at, let's say, 50%. And I know that we still have specialties that have huge wait times, and we have a lot of people that are still waiting. So I want to see the difference. What have we done?
That will be for them.
That would be for them to
Let's see the
respond
wait
to.
times starting at the beginning of the year towards the end of the year.
That's right.
Okay.
That's right. So how have we moved the needle for this year?
Got it. Thanks.
Thank you.
Other questions, comments? Central Health?
So, again, preliminary, part of our audit is looking at our 4 component units, and those of you who've been on the board know it's a detailed process that is just starting. But we anticipate having the audit results due in January. But the preliminary results indicate that we had about 107% of our sources over budget, and then 74% of uses under budget for the fiscal year. Just looking at the balance sheet, we had current assets of about $99.4 million and total assets of $281.6 million. Our liabilities are very low at just $28.5 million. And then our total net assets at $253 million for a total also of liabilities and net assets of $281.6 million. Looking at the sources and uses, we were over budget just slightly in our property tax revenue as well. Lease revenue was at $29.3 million and other revenue at 283% of that's going to be interest and other income, and then our tobacco settlement revenue. Our total sources of funds at $229 million for the year. Our uses of fund, the major component of that, again, is the $169 million of healthcare delivery, which I'll go into in more detail. Our total administrative costs were about $6.6 million, which was 74% of what was budgeted at $8.9 million. So our total uses were at $177.5 million, and our estimated sources over uses, which we talked about flows into next year as an available resource, is about $51.6 million. Looking at the details of the healthcare delivery, the major component of that is our intergovernmental transfers. We did make $12.2 million of intergovernmental transfers in September. And so we ended the year at just 84% of what we budgeted at $119 million compared to a budget of $141.5. Also, on provider costs, we did make a member payment to the CCC for $24.5 million, which is noted there. And a total IGT and provider costs of $150 million. We also have healthcare delivery operating costs, which includes our eligibility and enrollment department and other program costs. And that is at just 80% of budget at $6 million. And then finally, some other items that we outlined in the budget last year were the focus on the campus redevelopment, our ACA enrollment, and that includes our CHAP premium assistance program, and then our debt service. And those totaled $3.6 million. Our total healthcare delivery, as I stated earlier, was $169.5 million.
Our last chart just shows the intergovernmental transfers, and you'll see that we made uncompensated care payments of $12.2 million in September. Happy to answer any questions.
Sherry?
The IGTs, where are we now on that? Are we completely caught up?
We actually had one IGT that we made in October that we will reserve, that will be kind of, it was very small, it was about $4 million. That will be kind of carried for allocated, as we call it. I think if you've been here in the past when we had the DSRIP catch-up, we call that the allocated reserve. But that was paid in just in early October. But we did not have the significant
Backlog?
right. Like
Do we have any backlog still though?
No, just that timing that came
Okay.
right over the end of the year.
Okay. Right.
So you'll see that in the October that we had uncompensated care and dish.
So we won't have to explain that anymore, right?
I just, and you probably told us this before, but the difference between the 119 of IGTs that we actually made and the 141 that we had budgeted, why was that 21? Why did we not have IGTs for that? What was the reason for that?
So again, there's just the $4 million that is in October, but the other difference is really just what I think we call the haircuts, but also just what we are given from the state as far as those payments that are due for each of the hospitals. So
that actual
we'll
versus
see,
projected?
Yeah, it's actual versus budget. So we
Right, I understand that. I just, we
I will
projected
say-
141, and I'm just wondering,
we budget.
federal policy implications to this, or just maybe the hospitals didn't do as much Medicaid work that they were going to get reimbursed for?
I would say we budget very conservatively, and the way that we budget for IGT is we look at what the FMAP is, which is the rate we would get back into the community, and try to make sure that we're maintaining that level.
Okay.
So I think we try to make sure that we budget enough for the IGT. So, but there wasn't, other than there is the continued haircuts on some of these. There wasn't anything that we didn't foresee. And even, I think if you look at the DSRIP and things like that.
Other questions, comments, thoughts? All right, thank you.
Thank you.
All right, folks, believe it or not,
Are we there?
I think we are. Let me make sure we skipped around on the agenda a lot.
Well done.
Well done to everyone. All right, so we are at the last item, item 11, confirm the next regular board meeting, date, time, and location. The next Central Health Board of Managers meeting is scheduled on December 13th at 5:30 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702.
Move adjournment.
I second.
Any discussion?
Aye.
All right. Thank you all, very good.
Yeah.
Thank you.
Got through a lot.